This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Okay, awesome. Fantastic. Welcome everybody to the fourth installment of our Methods Core seminar series. Did the record button show up for everyone? I just want to make sure it did. Okay, thank you. Appreciate it. As a reminder, our previous seminar was the Human-Centered Design Methods to Achieve Preparation Phase Goals in the MOST framework with Andrea and Kelly. You can view that on Basecamp, SharePoint, and YouTube. So there are a couple places you can find that if you weren't present for the last one and want to check that out, or if you want to review it because it was excellent. As a note, we're hoping to transition these seminar recordings to be publicly available on YouTube. Before we go doing any of that, we're going to check in with the presenters, and then we'll also check in with anybody who shared something during the presentations, just to make sure you're comfortable with whatever you shared being publicly available. If not, then we will not make it publicly available, and we'll respect that. So that's a note on our previous presentation, and we're going to build on this prior topic by going into a little bit more specifics on human-centered design by looking at trauma-informed design research. So today, Topher, Andrea, and myself will be presenting on trauma-informed design research. And learning objectives for today's seminar are that after today, we hope that you will be able to recognize what trauma is and examine how trauma influences research processes through stories based on lived experience. And we really hope that today's seminar is going to empower you to begin implementing some of these strategies for drawing on lived experience with trauma to approach research with sensitivity, care, and compassion. And before we get into today's topic, want to make sure that we're doing a land acknowledgement. And for those of you that have attended prior seminars, we've done some form of a land acknowledgement. I'm personally really committed to these land acknowledgements as an ongoing dynamic practice rather than some static message that we repeat every time. If you remember back to, I think it was February, the positionality workshop that I did, I actually shared some of Dr. Anslus's work in the land acknowledgement for that. And he had a really fantastic interview recently, and he was speaking specifically to native deaths by suicide and settler colonialism. And I pulled out this quote, I think suicide can tell us something about the conditions of the land. I really encourage you all to listen to the whole interview. It's about 90 minutes, so it's quite long. But I wanted to show a quick clip today that I think starts to weave together land, suicide, and the topic of today's presentation. In the clip, Dr. Anslus is going to be speaking to a Canadian context, but the conditions, challenges, and complexities he discusses are still super relevant to our context here in the United States. And I know we have some Canadian collaborators on the call as well, so it may be particularly relevant to you all. I want to preface by saying the clip is going to be decontextualized a little bit because it's just a clip, but nevertheless, I really think it's useful for starting to weave together land, suicide, and today's topic. And are you all able to hear that? Did I do the proper share or no? No? Okay. Let me stop sharing and reshare. I should have thought of this. And I can share sound, and I think it will work now. Okay, are you seeing it again?
Yeah.
Fantastic. Someone just give me a thumbs up if you can hear it.
The most pernicious or difficult aspect to navigate today is the fact that behind the current maybe reconciliation and recognition politics that play out in Canada is a structure that is still fundamentally built on apartheid, a structure that is still fundamentally driven by logics of extermination and disposability of Indigenous people. And you don't have to look very far to see that. You can see it in water, you can see it in housing, you can see it in the fact that the government goes to court every year to try to deny equitable access to health service payments for Indigenous people, and Indigenous kids get, around 60 cents to the dollar in terms of public spending in health and social services and education across the country. And that's been known and well documented for the better part of almost 50 years. And people have, I don't know, maybe I'll use the word moral responsibility to think and act in good relationship to that violence. But partly why I harp on the issue of really rethinking and questioning the assumptions of mental health as a framework is because I think what you were referencing earlier about trauma and the kind of we're living in the trauma informed era is it's an example of something that internalizes what is actually quite social. Violence between people is not something internal. It happens materially between us. But when we think and sort of frame these issues solely as individual responsibilities, it's 100% commensurate with the political and economic projects of a neoliberal, capitalist, settler colonial society. And so disrupting that is about insisting that individual people, like the Minister for Indigenous Services, like the Premier of Ontario, have personal as well as structural political responsibility. That I think pushes us away from trauma-informed to more violence-informed ways of thinking about these kinds of relationships to place.
Yeah, very much.
So I know there's quite a lot to start with in our land acknowledgement here, but I think it paints a really good picture. And I think we'll hit on some of the points about trauma-informed and violence-informed lens. I think that gives us an interesting direction that today's topic could lead us to. That being said, kind of set the scene here. I want to take a moment to actually go into introduction for who's going to be presenting today. So I'm Lucas O'Brien. For those of you I haven't met yet, I'm a human-centered design research scientist at SCRC. I was born in North Carolina in Chapel Hill, but raised in Illinois just outside of Chicago. So I think I have Southern hospitality rooted in Midwest sensibilities, and that's kind of an approach that I bring to this work. I've got family experience with suicide loss and suicidality in the family. The picture here on the right is a picture of me with the cousin who's actually closest in age to me, Noah, who we lost 2 years ago to suicide. So it feels good to say his name, show his picture, and keep him alive in the work and presentations that we do. And I bring an intersection of engineering, design, and social work. I have a degree in materials engineering. I've worked in the design field before. And prior to starting an SCRC, I pursued an MSW. So I have that perspective and kind of lens that I'm bringing to today's topic. And I will hand it over to Andrea.
Great, thank you. I'm Andrea Hartzler. I think I had the chance to meet almost everybody. I was actually born at University of Washington, which is kind of cool. In the hospital there, and raised in Seattle, so I might be one of the only folks left who's from Seattle. I don't know, and still here. I'm a mom, I'm a sister, I'm a daughter, and we also have experience in our family, lived experiences. My son Lucas. And I last summer in the Tokyo Tower. My son's actually he graduated in linguistics, and of course this is an introduction of my son. You all know that, right? Always talk about my son, but he was a linguistics and Japanese major, and now he's teaching English over in Japan, which has meant we get to go and visit. So wanted to share that great photo of us last summer. And also the Northern Lights too, if anybody was in the Seattle area back in May, wanted to show that fun picture. It was really exciting. I'm interested in designing technology that promotes health equity. I'm really excited about today's discussion. I'm gonna stop talking and hand it to Topher.
Hi, everybody. I'm Topher Jerome. I am on the Lived Experience Advisory Board for SCRC, and I work at Harborview Behavioral Health Institute as project director. I was raised in southwestern Pennsylvania, northern Vermont. Oddly enough, on a hippie commune. There's a little bit about trauma involved there. I'm a husband, a brother, a doodle parent, and a traveler. So there's a picture of me and my husband, and then me and our wonderful doodle, Sydney. That picture was actually taken on Monday. I just loved it. I'm a multiple suicide attempt survivor, and have family experience with suicide. I've lost 2 nieces in the last 4 years, and we had the memorial for one just this month. So it's very, very much fresh in my mind. And my work over the past 20 years has really been dedicated to improving behavioral health, both in suicide prevention and in community behavioral health, and now sort of broader scale training, workforce, and policy innovation through the BHI. Okay, so I've met some of you along the way here and there. As I think I've said before, but I'll say it again, I'm not a scientist. I don't have an advanced degree in behavioral health, and so I'm not an expert. However, I've worked in and around behavioral health, and what I really am drawing on today is lived experience. What is trauma and how does it show up? There's the obvious, right? The violence, sexual abuse, disasters, witnessing horrific situations, that kind of thing, which can leave, war, all these, the things we think about when you hear trauma, right? And then there's the more subtle, like neglect, living with addiction, family, emotional abuse, shaming, and exposure to inappropriate things as a child. And I really want to emphasize the importance of some of the less dramatic, I don't know what you want to call it, forms of trauma, as a really as a trauma survivor who didn't live with outright violence. I was raised, as I mentioned, I was raised on this hippie commune in the Appalachian Mountains, and there's a lot of love, but there's also tons of neglect and exposure to things that kids shouldn't be exposed to, mostly sexual stuff. And, for me, it was really hard to believe that I had trauma. And it's always been confusing. I mean, people survive these horrific things that I didn't, but the evidence is in the ways I've learned how to cope with the world and the people around me, and my coping skills are not normal. And the reason behind that is true, and it's really evidence. You know, a lot of this came to light for me. I'm also in recovery from substance abuse addiction, and it took me years. I'm in long-term recovery now, but of 6 inpatient centers, 9 outpatient centers, psychiatric hospitalization, suicide attempts. This long sort of, I kept trying, and I didn't understand why. I had 5 years and I relapsed, and it's like it was just so baffling to me. And I finally, the last time I went to treatment, I went to Hazelden down in Oregon, and I went there because I had such a heavy focus on mental health, and and it changed my life. They said, if you don't deal with your trauma, you're never going to have long-term sobriety. And that was eye-opening to me. It's like, oh, the stuff I experienced was real, even though it was hard for me to believe it. And then, lastly, I'll just talk about, there's self-imposed trauma, right? Especially as being an addict, doing things that cause me shame, doing things that, and then having flashbacks about those things, right? So, and it's hard to believe, well, that was my fault because I was an addict, right? And I think there's a lot of people, especially in the suicide space, having shame around being suicidal, having shame around having attempts, having shame about feeling like you're a different person or you don't fit in. There's so many different levels that trauma can have in there. And then really think about how does it show up, right? I've talked about, how a lot of how it showed up for me, but of course there's the intensity of like flashbacks, painful memories, that lead to needing to escape those feelings, suicide, drugs, self-harm, which is also part of my story. And there's all these subtle, unspoken ways we learn to cope. For me, a lot of that has to do with seeking approval. People's disapproval of me feels or felt life-threatening, right? And so I would go to extreme measures to try to make sure that everybody around me was okay all the time. And, that's exhausting. I'm projecting an image on the stage for people to love. And people love this image that I'm projecting. Meanwhile, I'm backstage crumbling, dying in shame and despair and self, those feelings. And so really trying to see and recognize that in the people that we're working with, especially when you're thinking about talking with people who are suffering with suicide, suffering with addiction, all of this stuff. Getting to the person who's behind the curtain is important. And we have to think about ways to do that with compassion. I got into suicide. I have no idea where I'm at in time, but I'll try to get through this pretty quickly. I was working for Jasper, which I know is being used in part of this work, but which was an app to help people who are suicidal in the emergency room. And I wasn't a researcher, but I helped develop this app, and I did a lot of the bedside research, both in the formative and the RCT afterwards, where I would go into a lot of time at Mayo and other hospitals in the Midwest, but where I would go in and talk with people who are suicidal. And, before we launched into some of this, we're in the staff meeting at Jasper, and they're going through the measures. We're going to, ask people, an hour's worth of questions, many of which were repetitive, right? Personal, deep, like probing questions. And I just sat there in this meeting and I felt myself feeling agitated, like we can't do this to the people who are suffering, right? This is too much, right? We're not talking about breakfast here. We're talking about people's lives. And the experience I've had both in inpatient, wherever the settings have been, where people come in and you ask you the same damn questions over and over. The next person comes, same questions over and over. It's like, isn't anybody listening to me? It's just that feeling is just awful. So anyway, we really had to step back and say, seriously, what are the measures we really need to ask? And then asking ourselves, how are we approaching the people who we're asking these questions with? And so for, at least in the formative stage, I used my lived experience as a way to build relationship with the person before we got into the heavy stuff. Anyway, yeah, so we need to go on to the next thing. I just want to end with, we need to move away from the idea of what's wrong with you to what happened to you. Anyway, thanks. Oh, this clip is great. It's a short description about what is trauma, and then we're going to move into a breakout session afterwards, because we want to talk about your response to this definition to trauma. So anyway, Lucas is going to play the clip and then we'll go from there.
So let's define trauma in the context of design. Now, before I go to the next few slides, I'm keeping us at like 30,000 feet. So I'm not going to go into specific traumatic experiences. I'm not going to even like break down the different kinds of trauma. I feel like that takes just much more time and breathing room to let that kind of hit us and to let it sit for a bit. So think about this in the context of the work that you were doing, no matter what you were doing. So trauma is a response to anything that is overwhelming and that happens for too much, too fast, too soon, or too long. And the thing that makes something a traumatic experience for someone is that it is coupled with this lack of protection or support. And one of the things that I love about this next part of the definition comes from Resmaa Menakem, and he says it lives in the body. So it's stored as some kind of a sensation. It's either could be pain or it could be tension, or it's a lack of sensation like a numbness. And the other thing that is unique and is really important about trauma is that it does not impact all of us in the same way, and that the context in which it occurred or that it occurs is critically important. So this is a lot, and this is a big definition, but it really centers so much around something that is too much, too fast, too soon, or for too long. And it's that coupling of that lack of protection or support. So it could come from someone that you know, could come from someone that you don't know. And like I said, the impact is very, very, can be very different. I'll share a brief example that came from the book from Bruce Perry, Dr. Bruce Perry and Oprah. And in one of the earlier chapters, he gives us an example of how a third grader and a fifth grader both experienced a fire that happened in a grade school. And he talked about how the different individuals in that environment, in that context, reacted and responded differently because of their closeness, their literal proximity to the event. He also spoke about just age being a factor, someone's like resiliency being a factor. There is reference to a firefighter that had a different kind of response because they have responded to other things maybe multiple times. So it helps to just really think about the specifics around context.
I love that definition of trauma. So when Lucas first shared that clip with us when we were thinking about putting this together, I heard that and I just started thinking about that definition. It's like, oh, this thing that happened in my life, this thing, then I'm distracted thinking about that definition of trauma really made me reflect on my own experience. And so with that, we wanted to have a breakout for a few minutes reflecting on, how did Rachel's definition resonate with you or with your understanding of trauma? And, thinking about what does trauma look like, feel like? You're welcome to share your own experiences, or if you want, you don't need to by any means. It's just a gentle reminder that but if you do want to share something about how it personally affected, the definition personally reflected on, sorry, I got distracted, please feel free to do so. And then we'll come back to the main room and we'll share out some reflections. Welcome back, everybody. Is that everyone?
Okay.
Yeah, I think that's everybody.
Okay, great. Well, welcome back. Just would like to spend a few minutes if people want to share about what you're going to take away from your breakout discussions? Anything come up for you that you'd like to share with the group? If not, that's fine, but just want to give an opportunity for people to speak up if you like.
So for this didn't come up in our breakout, but I just want to thank you for sharing your personal experience. And I think it was especially helpful for me to hear you explain how your experience of trauma was not experienced immediately as traumatic, but that it was something you recognized later in life was continuing to affect you, and that you may not always be able to label it that way in the moment that it's happening, but that doesn't mean that it's not affecting you and that you're not carrying it with you. So I thought that was helpful. And also the example in the school of the fire, that the two children experienced that event really differently, even though they were both exposed to the same traumatic experience or potentially traumatic experience. That was helpful for me to think through too.
Thank you. Okay. Anybody else have anything they want to share? I think we can move on to you know, let's just acknowledge that trauma impacts us all. I think if we look, everybody has had trauma at one level or another. And that trauma shapes our experiences. You as researchers and research participants, and the research participants, and that our lived experience of trauma, and that's probably all of us, can help us find sensitivity and caring in the research process for ourselves, for our coworkers, collaborators, and our participants. So then we're going to go to Andrea.
Great, thank you. So we're going to go back to Rachel Dietkes's materials, which I believe, Lucas, you're going to provide everybody with a link to that later if you want to deep dive. But I wanted to, we thought it'd be helpful to talk about some of the principles that Rachel goes into later in that talk on YouTube about guiding principles for trauma-informed care. I'm sorry, trauma-informed design based on SAMHSA's principles for trauma-informed care. So we're going to do this as a fireside chat, but first I want to provide the definitions just briefly to keep in mind as we share some of our experiences as researchers and folks, all of us, as Topher mentioned, with lived experience that we can bring to our research. So the first, and these principles are based on the SAMHSA's principles for trauma-informed care, which Rachel Dietkes adapted for thinking about design, right? And thinking about the DDBT model for us as a center. So the first thing that's most important is safety, right? And making sure that people feel emotionally, physically, psychologically safe when participating in the design process. This is like the very first foundational thing that has to happen. One thing that Rachel talks about that I thought that really struck me is it's not just the research participants, that's critical, but it's everybody in the process. It's us as researchers, it is the leadership, it's staff, it's everybody on the team really feeling safe. As Topher mentioned, we all have experienced trauma. Things can come up for all of us, even if we're not sitting in that research participant seat, even though sometimes we think about that.
Okay, just throw on something really quick. I just think it's so important to include people who have lived experience in your design process, just because learning what's going to more helpful to be safe for the participants, it really helps to have somebody with lived experience who can help inform that.
Yes, thank you for that. And I'll just bring back to it's not about breakfast, it's about people's lives. Just to quote a famous person named Topher, Jerome, right? And we don't know that unless we check in with people's lived experience. How are they experiencing this research, and establishing that safety? The next thing is trustworthy and transparency. So if we've got safety, then it's important to have transparency in the process so that everybody trusts in the process. And that means having a foot in the game. So all design decisions should be conducted transparently. We shouldn't be hiding things. We should be sharing how we're making decisions and doing that inclusively whenever possible, to build and maintain trust for everybody who's involved, as well as anybody who might in the future use the designs that you're creating, right? So listening when Topher says there's no way that someone can complete 90 minutes worth of questions in a 15-minute visit. I'm exaggerating some, and also, asking people to relive some of these experiences. That even adds another layer. So thinking about that and listening and building that trust and transparency. The next one is peer support. This is something that we've talked about, the value of peer support for participants, being able to check in with other people, bringing our own lived experience into the research process to be peers, not only to say participants, but to one another. So we can also involve other people and talk with others in our lives who might have lived experience that could bear on the research process. That can be really valuable to be able to enrich the center. Collaboration and mutuality. This is really, really important. And I think it speaks to our DDBT process, is that as designers or researchers, we recognize that healing happens through critical consciousness, meaningful sharing of power and decision-making. We're always striving to involve people in ethical and what Rachel calls radical participatory design. So really taking that to heart and sharing power and having not just our research participants, but everybody have a say in true collaboration and mutuality, where we're not just benefiting as the researchers, but everybody wins. Empowerment, voice, and choice. We strengthen and empower the experiences of the communities we are inviting in. So echoing back to Topher, that lived experience is critical. Not just tokenizing that, really listening to that and responding to that. And building that into the process and the outcome of our design. We also need to recognize that every experience is unique and may sometimes require a more personalized approach. So Rachel talks about this too, kind of what's kind of a one size fits all versus individual personalization. That's a line that's really important to pay attention to and think about carefully. And it was echoed in Rachel's description of the kids and even the firefighter who may have responded differently. We need to think about that. And last, cultural, historical, and gender issues. I think Dr. Anslus, I think I'm pronouncing his name, at the land acknowledgement brought this up, right? The importance of recognizing the biases that we all bring through our cultural learning, and thinking about that moral responsibility that Dr. Anslus brought up to disrupt, and just give yourself that permission to be open and aware, and think about how that may play into the work that we do together, and try to mitigate it. It's hard, but it's important to recognize. I'm going to stop there so that we can move on to our fireside chat unless folks had additions or questions on these 6 principles from SAMHSA for trauma-informed care, and how we can think about it in terms of strategies for designing tools for the center. We thought what we do now is transition and do a fireside chat where we'll ask each other questions. And as you're listening to the responses, we'd invite you to use the chat to think about what principles are you hearing come up in the lived experiences that Topher, Lucas, and I are gonna share. So just go ahead and just list out, could be bullets, doesn't have to be a long thing, but what are you hearing in these stories? Topher, Lucas, anything else before we
You did a great job.
Oh,
Yeah.
thank you. And Rachel does a great job too. So I encourage you, if you're interested, go and listen to her talk. I'm just sharing what she's really put together. So I'm going to ask first question. I'm going to ask Topher if you would like to share a story that resonates with you for one or more of these principles that you'd be willing to share.
Yeah, of course. So much of the research, well, all of the research we were doing when we were building the app was in emergency departments and psychiatric hospitals. So not the primary care clinic, but I think the experiences can be very similar. Talking about these measures, right? And that feeling of being uncomfortable with having to go through all of these things with somebody who's in a crisis, especially in some of the intensity of the settings. And there was one woman in particular that comes to mind. This was at Mayo, and she was, probably late 50s. I don't know. And she was really distressed, but she had been identified as somebody we could approach. So, I go into the room, and it was just so what was interesting was I started in on my little spiel, let's do the informed consent, and that whole process is I can talk about dogs growling. Anyway, so I asked her, I started in, and she just was, she'd answer one question and then she'd start ruminating and getting really distressed around the answer to the question. And so I just stepped back from it, and I got real with her. I've been in your shoes. I know what this feels like. I used a little bit of my lived experience, and I built some relationship. I validated what she was going through, and she calmed down significantly, and we got through the whole interview. The other thing that I've done, it's separately from that particular situation, but was going into the room, especially again, the formative, where we had more flexibility in how we approach people and work with people. But it was explaining, I'm about to ask you all of these questions. This stuff is really personal. And these questions, I know other people have been asking you these same things. And so it may feel, it's like, I get, I've been in your shoes. I get what it feels like to answer the same questions, really explaining about how it is these questions are going to help inform the work that we're doing. Why am I asking these questions? And then letting people know that it's okay not to answer questions if you're not comfortable. So really trying to, again, coming from a relational experience, looking at transparency, how do we, what is it that we're actually doing? And then trying to take care of the person in the moment at the same time. So
Yeah, Topher, what you're sharing there just about some of those initial setups to conversations are making me think of some work that I did. I was on a project when I was at a design center at University of Illinois, and I was a design researcher consulting with a nonprofit in Chicago, specifically focused on reducing gun violence on Chicago's South and West sides. And so this nonprofit was transitioning from having job placements into the community to actively having in-house employment opportunities at this factory that they were going to have. And so they were asking our team, how could we support a culturally relevant workforce environment in this new factory? Design team showed up to talk to some of the guys who were involved in the program. And there was just this palpable skepticism immediately, and rightfully so. Who were we to come from university to ask them about their super challenging experiences? And I remember sitting in the room as we were about to do some interviews with these guys, and just you could feel the skepticism, and it felt really justified. And so I had this moment of, well, why should they trust us? Like, what have we done to show that we're willing to engage with their world? And so the first event of the day was this boxing class, and we had all showed up in our university business casual clothing, and I just set backpack to the side, and got boxing gloves on, and joined this class, and you could feel the mood shift as I participated in this. It meant I was discussing, I was gross and sweaty for the rest of the day as we were doing interviews. But as we sat down, there was a level of I don't even know what the right word is, just an understanding that I was willing to jump in and participate in a little bit of their world. And so I think that made a huge difference in the rapport we were able to build in these future interviews. That being said, one of the things I think we really failed to do in this project was, as we were presenting at the end, I didn't, or our team did not acknowledge the ways that cultural, historical, and gender issues play into what does it mean to be professional? What does it mean to be in a workplace? We didn't name racism. We didn't talk about the way that white supremacy culture is deeply intertwined with our standards for professionalism. We didn't talk about the ongoing traumas of redlining, effects of that's had on the neighborhoods that these guys were coming from, and how that might show up in workplace experiences. So I think we had some things that we did well in this project, and that experience that I shared joining the class. But I think ultimately in our final presentation, we were really lacking and didn't fully embody all of these principles. So there's a lot I wish I had done better in that project. Andrea, I'm wondering if any of that resonates with you.
Yeah, that's thanks for sharing that. I think we can learn so much from, not only things that we've done well, but areas where we could have done better looking back with a lens like this. For the story that I wanted to share is an interesting one too, of kind of vulnerability too, and recognition. I have a largely research team that I lead on a study looking at implicit bias and patient-provider interactions. And a few years ago, we were interviewing patients about their experiences of discrimination in healthcare, which is a really sensitive topic. And we put a lot of thought into how do we approach this with sensitivity and compassion? And we wanted to make sure that the folks that were doing the interviews had lived experience and could, bring that to bear and establish rapport. And are we doing everything right? Check, 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 right? Kind of that mentality almost when I look back. And the students, the PhD students who were involved, had this fantastic idea of let's check in with the bioethics consultation, which was a service that we have through our CTSA here at the University of Washington. So they went, and I was just so proud, and they came back and said, guess what we learned? And, got some really great ideas about, that kind of reinforced what we were already putting a lot of effort into thinking. But the big gap was, the bioethicist said, well, what are you all doing for yourselves to protect yourselves? And that's when I got the feeling in my stomach, like, oh my gosh, this is bringing up experiences for not just the participants, but for our team members. And we need to think about how to put supports in place for the trauma experience on the team. So that I always think back of that. That was just a really raised my awareness of how much trauma affects us all, and thinking about everybody involved. And it's important to think about participants, but not Topher, you talked about when we've talked about this before, kind of fragilizing. I can't remember the word exactly, but overdoing it. So I think there's some good lessons there. Pat, I see your hand up.
Yes, thank you for sharing that. And that was, that just took me back to my work in safety net hospitals. So not quite research, but the idea of making sure our team feels safe is hugely important, and something that we often will neglect. And one thing that I've kind of learned during my clinical practice is that sometimes if our team doesn't feel safe, then sometimes they reactively might respond to patients in a way that might harm the interaction as well, right? So, I mean, in situations where we're under pressure, that's when our biases tend to manifest. So making sure the team is safe is great for the sake of the team as well, but it's also good for the sake of the patient, or if you're looking at the research cohort or whatever, what have you. Because if everyone feels safe on both sides, then that enhances the interaction and allows us to be more collaborative and be more there for the people, that we're trying to serve with our work.
Those are such great.
There was a, can I respond really quickly? The intern, so important to take care of the researchers. We had a new research assistant who is a fresh social work student join us at Mayo, and we're in this room with this person who had made a serious suicide attempt, and there was physical evidence, on her neck and bandages that had slipped down, and I was pretty desensitized to this kind of thing, and I just talking with the person. Meanwhile, this research assistant was so traumatized by what she was seeing visually. And when we left the room, she fell apart. It was like, oh, and I think that really highlights the importance of we need to build in the ability to debrief. The researchers need the chance to debrief and talk about challenging situations, and then also learning what went well and what didn't go well, and what can we learn and take into the next session or the next room. So
Yeah, maybe I'll wrap up here with the fireside chat, just a reflection, even on today's seminar, where we were trying to be, incorporating these principles as much as possible. I didn't say before we went out of the breakout rooms, breakouts are optional. And if you don't want to participate in that discussion today, you don't have to. So, I think this is an ongoing process of where can we do better? How can we improve? And so just kind of reflecting, even in today's session, there's things we could have improved. I'm going to wrap up here just because I'm keeping an eye on time. We've got about 5 minutes left. I hope that today's conversation and presentation was insightful, useful for all of you. Really want you all to, I want to encourage teams to set 20 minutes aside in your next team meeting to discuss what today's seminar brought up for you. You may want to talk about what trauma looks like, feels like, maybe revisit Rachel's definition and just discuss what resonated. Maybe you want to do a fireside chat of your own, any stories or strategies that you have from your experiences that align with the 6 guiding principles. Maybe it's ways that you can further integrate and invite lived experience into your research process. Maybe this prompted some ideas, some strategies,
Collaboration, mutuality, design.
Oh,
Sorry, I'm grabbing the link. I'm sorry.
You're good. You're good.
I'm grabbing Rachel's link to put in the chat. Ignore me, please. I'm gonna mute myself.
No worries. That's all right. The last thing I was going to say here is that maybe today had brought up some questions or concerns that you want to discuss as a team. So encourage you to carve out those 20 minutes, imagining you meet for maybe an hour a week or every 2 weeks. So we're not asking you to take a whole meeting for it, but just 20 minutes to start to reflect on today's discussion. I also pulled together here a list of people and organizations and some suggested resources for you all. This is by no means comprehensive. And what I did for some of the links to the people, I just linked their LinkedIn because that usually has ways you could find them in other places. I think these are folks that are being more open about this conversation around trauma-informed design practice. And then in the resources, there's an academic paper, there's a YouTube video, Rachel's YouTube video is linked in there. There's a web article, and then another video from a conference recording. So encourage you all to check those out. I think they're all good listens. And I will transition here just as a setup for July, our next methods course seminar series. We have innovative approaches to propel suicide research. So stay tuned for that. That actually took me less time than I thought. So we have 2 minutes if anybody wants to jump in with anything, any closing thoughts or reflections.
I dropped my email in the chat. If anyone has any questions, wants to follow up, wants input on anything, feel free to reach out.
Thanks, Topher.
Great. welcome.
Oh, I appreciate all the appreciation in the chat. You guys are wonderful.
Thank you all for doing the work that you're doing. This is important stuff. So as somebody who's
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.